Okay, let's go ahead and get started. Welcome everybody to the first EON Center of Excellence monthly webinar series. As I said, this is a monthly series that's going to focus on process improvement topics as well as clinical topics with the overall goal of improving incidental pulmonary nodule management, lung cancer management, and then ultimately improving outcomes in lung cancer. With that said, I am Dr. Scott Skibo, pulmonologist, CMO at EON Health. And again, I'd like to welcome everybody. The box at the top, there's a question and answer. If anybody has questions throughout this webinar that you'd like answered, we're going to have time at the end to answer questions. So please type those in there and I will do my best to give you a good answer. So let's get started. Deliver exceptionally high levels of care to patients with incidental pulmonary nodules and provide support to these programs that are striving to achieve superior patient outcomes and improve survival rates in lung cancer. So what is unique to this program? So what makes our program unique is, number one, we're focused on incidental pulmonary nodule management. So EON Health has been laser focused for the last 6 years on these incidental nodules, because we know that 95% of nodules that are discovered incidentally. So in order to have a stage shift to make a meaningful impact in your community, these need to be managed appropriately. The second thing is data-centric measurements of success. So the EON Center of Excellence, standards of care anchored to clinically based guidelines defined by data-centric quantifiable measurements of success. And then lastly, 3 accreditation tiers, which we'll go over just real briefly: the bronze tier, silver tier, and lastly, the gold tier. So the bronze tier focuses on patient capture, right? So the first step that has to occur in incidental nodule management is actually identifying the incidental nodule and making sure that it's there to provide appropriate follow-up and care. The second tier, the silver tier, is appropriate adherence. And then lastly, the gold tier is the fully integrated program in which incidental nodule programs achieve and incorporate central oversight, decision-making, processes, and workflows to achieve the best possible patient outcomes. And certainly for more information on this, the website is listed at the bottom of the page here. Please visit that, and there is a vast amount of information on that website. So what are the expected outcomes of the EON Center of Excellence program? So what do we want to achieve, and what do we think is going to be achieved? Number one, and it all starts and ends with better patient outcomes. That's why we're doing this. Number two, we want to standardize best practices. We want incidental pulmonary nodules to be top of mind awareness, increasing patient satisfaction, positive word of mouth, and then lastly, competitive advantage, which again goes back to the first thing, which is gained by better patient outcomes to drive that competitive advantage. So it's certainly a win-win. All right, with that said, let's get to what we're going to talk about today, which is the title of my talk is Improving Community Outcomes in Lung Cancer. It all starts with the incidental pulmonary nodule. So as I alluded to earlier, 95% of all pulmonary nodules are found incidentally. Without question, lung cancer screening has got the majority of the press over the last several years. It's certainly an important part of a comprehensive program, but without managing incidental pulmonary nodules appropriately, seeing system-wide stage shifts on a community level is not possible. And it's only by incorporating these two, but most importantly, doing the incidental pulmonary nodule part of it well. So what's the scope of the problem? Well, we all know there's a lot of CT scan, chest CTs performed in the United States yearly. You know, according to this source, approximately 5 million or so chest CTs are performed per year. 1.6 million of these scans are going to detect an incidental pulmonary nodule. So that's a lot of scans. 63,000 are a lot of nodules. 63,000 of these patients will receive a lung cancer diagnosis within 2 years. Now, the bigger part of the problem with this is not the magnitude of how many nodules are being identified, but it's how few of these nodules are receiving follow-up. So nationwide, more than 2/3 of these nodules, so roughly about 70%, do not receive follow-up. Put that another way. So if there's 1.6 million nodules identified in the United States yearly, 1.1 million of these do not receive follow-up. So the way that I think we all think about patients are, well, you know, that's 1.1 million people that could be our neighbors, family, ourselves, right? That have a nodule that's never followed, right? And that does not lead to the best outcomes. So compounding that with the scope of the problem is the average time from initial identification of an IPN to first workup is 8 months. So not only are we not following these, you know, as a medical community, we're taking a long time to do anything about them when they are followed. And as you can see on the right side of the slide, we're looking at 5-year survival for pulmonary nodules. So if you look at the most recent guidelines published in Chest of 2017 for 5-year survival, you know, 1A1, 5-year survival is 91%, 1A2, 84%, 1A3, 79%. So these are the nodules. You know, a pulmonary nodule, of course, is 3 centimeters, you know, less than 3 centimeters. So 0 to 1 centimeter, it doesn't take very long for like a 0.8 centimeter nodule to go to 1.1 centimeter nodule. And all of a sudden you went from 1A1 to 1A2, and you just decreased 7% in 5 years survival. So it's important to not only identify these, but act on them quickly to optimize patient outcome. As a result of all those things, we all know this statistic, which is most of the lung cancers, non-small cell lung cancers in the United States are diagnosed late. So 41% stage 4, 24% stage 3, and then only 35% at the earliest stages, either stage 1 or stage 2. So what nodules require urgent evaluation? So when we're thinking about an incidental nodule program, we get a lot of nodules. What type of nodules are we getting? And which ones do we need to act with urgency, right? So all the guidelines are based on either nodule size and growth rate. And despite you know, emerging literature on other ways to follow these nodules, they remain the most widely used predictors to assess malignant probability. You know, as you can see here from the literature review panel on the right, if you have a nodule that's greater than 10 millimeters, you have, depending on the source, between a 33 to 60% chance of being malignant. And if it's greater than 20 millimeters, 64 to 82% chance of being malignant. So these are certainly the ones we want to act on. We want to know if they are cancerous as quickly as possible before that 1A1 or 1A2 progresses into a more advanced cancer, because that's ultimately how we improve outcomes. So this is a study that was published in 2015 in the American Journal of Respiratory and Critical Care Medicine. Essentially, they looked at in Southern California, in the Kaiser Permanente system, what type of pulmonary nodules were being found, and they put them in. They put percentage by size, and it turns out that what they described in the Southern California population is 55% of the nodules that are found incidentally require, by the guidelines, either tissue sampling, PET CT, or 3-month CT, again, per the current Fleischner Society guidelines. So more than half of the nodules in this study would require urgent workup. Now, the downside of this study is, well, does this really apply to the country in general? This is Southern California. Smoking rates may not be the same as a lot of the rest of the country, et cetera. So the data that I'm going to show you now comes from, it's from internal data from an 88 hospital system, which is geographically diverse. So spans from coast to coast, south to north in the United States. And we found very similar findings, with the exception of looking at 14,013 incidental pulmonary nodules greater than 4 millimeters. We found a higher percentage that are greater than 20 millimeters. So 24% of the nodules identified were greater than 20 millimeters. So what does this mean? So based on the literature review and the percent of these nodules that are malignant based on size, we can expect out of that 14,013 nodules, between 3,474 of them and 5,173 of them are going to be determined malignant. Now, this isn't doing anything to change the prevalence of disease. These are ones that will ultimately come to clinical care or clinical attention. Our job, though, is to find them before they come to clinical attention. So when they're identified by the radiologist, this is our opportunity to create a stage shift and ultimately improve outcomes in lung cancer. So I want to share with you my program, that when I was in, clinical practice before I took the position as chief medical officer at EON, what my program looked like before we implemented EON and after we implemented EON in the first year after. So beforehand, we saw really what a lot of the rest of the country sees, which is mostly stage, almost half of it was stage 4, 32% stage 3. So, you add those up, and we in Western North Carolina, we were seeing 80% of our cancers diagnosed pre-program as either stage 3 or 4. Now, as everyone's aware, stage 3A may be considered surgical disease, but 80 to 85% of the time nationwide, these patients do not go for surgery. Now, fast forward, we implemented EON, and what we saw was dramatic, in my opinion. So now, instead of 80% stage 3 and 4, we were seeing, number one, we diagnosed more cancer. Again, not because there's more cancer out there, we're just finding it earlier. So our cancer number went up, but more importantly, more than half was stage 1 or 2. So 56% were now stage 1 or 2, where it was 20%. Now, the proof of that really is like, well, what happened to our patients? So in that year, 54% of our patients, so again, over half, went for curative intent treatment, meaning surgical resection or stereotactic radiosurgery, so SBRT. So adherence, right? So we talked about at the beginning of this talk, well, geez, only, about 70% of these nodules don't get followed, right? So if you look at the left panel here, incidental nodule adherence rates. Here's what we look like in that year, that first year, where we followed 1,206 incidental pulmonary nodules. 1,189 of those patients were adherent, with 17 of those being non-adherent. So our adherence rate went to 98.6%. In the right panel, we talk about lung cancer screening. You can see our adherence rate there, but really what we're focused on today is incidental nodule adherence rates. So the other thing that happened as a result of incorporating EON into our care team or into our medical center is time to meaningful treatment decreased to 12.8 days. Now, I'm not talking that at the beginning of the talk, I talked about that 8 months from when a nodule is identified to whenever somebody thinks about doing something about it being 8 months. I'm talking about when a nodule identified, we diagnose a nodule as cancer, and then meaningful treatment at that point got down to 12.8 days. Now, this isn't all just because of EON, of course, but EON was the impetus to be able to bring these to our attention immediately, so we can get these patients in immediately, get their biopsy, if indicated, done that week, and all the rest of the workup. And it also required buy-in from, the medical oncology team, radiation oncology team, thoracic surgery, all of which were excellent at making sure our patients got seen rapidly. And as a result of which we were awarded for a community hospital Center of Excellence designation in lung cancer. So what are the future directions? Well, first step is now, right, is to make sure that 70% of the nodules that are currently not followed get followed, right? We need to determine which nodules are suspicious enough, right? So one of the problems is we have to be very cautious that we make sure patients avoid unnecessary diagnostic and therapeutic procedures. Because if you look at some of the data, 23% of patients who underwent surgery for suspicious nodule, had a benign diagnosis. So, I'm always glad when people have benign diagnosis, but that's a tough way to find out that you have a benign diagnosis. When the surgeon says to Mrs. Jones, great news, it wasn't cancer, but the bad news is you lost part of your lung to find out it wasn't cancer. So, I think that's an area of that's ripe for improvement. And then if you look at the total diagnostic cost of nodule evaluation, 43.1% of it was from patients without a lung cancer diagnosis. So the biopsy costs, et cetera. So currently, size and growth rate are the best predictors of malignant probability. Radiomics, the field of radiomics / computer vision, offers promise for the future, and I think does have a lot of promise, but it's not yet ready for prime time. It's going to require further validation and larger prospective randomized trials, which investigates the actual clinical impact on, most importantly, patient outcomes. So we have to show that using radiomics actually has outcome measures that are beneficial to patients in the management of lung cancer. Because ultimately, as you can see on the right, the goal of any program is to create a stage shift and ultimately improve survival in lung cancer. So in conclusion, I think you'll get no argument from anybody in the lung cancer field that appropriate incidental pulmonary nodule management is currently the best opportunity to create a meaningful impact in improving lung cancer survival. I know there has been a tremendous amount of movement forward in the medical oncology space and radiation oncology surgical techniques, but still finding these things early, identifying them, making sure there's adherence, and then centrally integrating the program is the best opportunity for making an impact in community outcomes in lung cancer. Remember, lung cancer screening is important, but 95% of nodules are found incidentally. It requires both incidental pulmonary nodule management and lung cancer screening to get the best stage shift and the best care in a community. We're not finding just a lot of little tiny things. We are finding that more than 50% are greater than 8 millimeters. Currently, I know we talked about this plenty, 30% are followed, only 30% are followed appropriately. Utilizing a system like EON, which utilizes computational linguistics to maximize both sensitivity and specificity. Traditional natural language processing, so brute force NLP, you can catch these nodules, but you end up having a lot of false positives, and that is the definite advantage of a computational linguistics approach versus natural language processing. And size and growth rate are the best predictors of malignant probability. And again, radiomics, holds promise for the future. So lastly, I just want to make sure everyone's aware of Nikki Hilt. Our job at EON is to support every single one of the programs at the, for the EON Center of Excellence that are in the EON Center of Excellence program. And Nikki is the champion for that. She is all things ECOE. Her job is to make sure that every single program is supported, has the resources to go from bronze to silver to gold and beyond. We will, of course, continue these educational webinar series. This could be monthly. The topics, as I said at the beginning, are going to be a combination of process improvement topics as well as clinical topics related to pulmonary nodules, lung cancer care, and improving outcomes. And then, of course, on the website, which I put on that slide at the beginning, there are a lot of resources there as well, that a lot of resources that come as being part of the EON Center of Excellence program. So with that being said, I thank you all for your attention.